Good morning, Assalamu alaikum everyone. I'm Dr. Shirin Pyarali. Today we will going to discuss some points and facts about the vesico-vaginal fistula, its management at our setup, and we will try to discuss some new innovative findings and concepts as well. So I would like to ask Dr. Daniel. He's live with us from Sakhar. Daniel, can you hear me?
Yes, madam.
Okay, please start.
Okay. Assalamu alaikum. I am Dr. Mohammad Daniel Iqbal. The topic of presentation is, as already told by Dr. Shiri, vesico-vaginal fistula. Vesico-vaginal fistula is an abnormal communication between bladder and the vagina. It is most common acquired fistula of urinary tract. The patient have continuous leakage of urine per vagina, which have a devastating effect on patient's quality of life. Causes of vesico-vaginal
Dr.
fistula.
Daniel, please wait. We are not only discussing VVF, we are discussing urogenital fistula. So, if any question regarding all this topic, we can also discuss that as well. Yes, Daniel, please continue.
The causes of vesico-vaginal fistula includes traumatic, which includes post-surgical like abdominal and vaginal hysterectomy, colporaphy, vaginal or bladder biopsy, or ERBG or laser therapy. The external trauma, which includes penetrating trauma and associated pelvic fracture or sexual assault. Then radiation therapy and advanced pelvic surgery, infections and inflammatory causes, which include inflammatory bowel disease, pelvic inflammatory disease, and TB. Then foreign bodies like pessaries and or sexual sex toys, congenital causes. The most common cause in developing countries is obstructed causes, which include obstructed labor, forceps laceration, uterine rupture, cesarean section, injury to the bladder.
So basically, in third world countries or the low income countries, the most common cause is obstetric injuries, either from one way or another. It could be either the prolonged obstructed labor, or it could be emergency cesarean section. While in the international or the developed world, the basic cause is the considered as hysterectomies, and specifically abdominal hysterectomies, in which they meant for any carcinomas. So this obstetric causes are most common on our side, but the radical hysterectomies are most common on their side. Yes, Daniel.
Then the risk factors include tobacco use, the larger uterine size during hysterectomy, or greater blood loss. Previous uterine surgery which leads to fibrosis and poor demarcation of surgical plans, and endometriosis, infection, obesity, and prior radiation therapy.
In prior radiation therapy, either from one cause or another, it has been found that the fistula can be developed after an interval of 6 weeks to 1 year, or sometime 1.5 years. And the management of this radiation fistula is likewise. That is, we give ample time to the patients to let this fistula heal. It usually makes around 1 year or two, but most of this patient ended up in not repair of fistula, but in urinary diversions. Yes, Daniel.
Then evaluation and diagnosis. The VVF must be distinguished from other causes of urinary incontinence like stress incontinence, urgency incontinence, or overflow incontinence, and it may also be must also be distinguished from ureterovaginal fistula. The presentation of patient is usually complaining of urine leakage from the vagina. The amount of leakage may vary. The more the leakage, the more is the size of fistula. Abdominal or pelvic pain or distension post hysterectomy. Post abdominal hysterectomy, prolonged ileus, abdominal distension, hematuria, vaginal discharge, elevated WBC count. The VVF after radiation therapy may manifest after months or years.
This post-abdominal hysterectomy presentation, which as Dr. Daniel has shown, the prolonged ileus abdominal distension, it's most likely not due to the vesico-vaginal fistula alone, but rather it's usually present in the complex fistula, which includes either ureter or ureter along with other organs of genitourinary fistulas. Yes, Daniel.
Then examination. The per vaginal examination, vaginal anatomy, including depth of vagina and associated prolapse, atrophy, interstitial size, all must be noted as all these factors affect the repair of the fistula.
Uh,
Uh,
Wait a second, Daniel. Can anyone from audience please tell me what is the concept of vaginal atrophy and how it can affect the healing of the fistulas? This is a more burned question in recent literature. And what can we do to optimize? Yes, Noman?
Atrophic vaginitis is the term which is mostly normally after the menopause, the female patient usually have, or after some condition when there is a hormonal imbalancement.
Yes.
So to optimize the patient with atrophic vaginitis, there are recommendations to use of the intravaginal steroids,
Yes.
so that the patient and it hinders in the healing of VVF after repair, or if the VVF is very small, we are thinking that it should self heal if it is minute, but in the presence of atrophy it will not heal. In the presence of atrophy there will be no further increase in the layers of vagina and shedding of the normal vagina, abnormal debrided cell.
Basically, the atrophy leads to reduced level of estrogens, and in case of reduced level of estrogen, the healing and the vascularity is compromised. So, in order to get a good vascularity, either the patient should be estrogenized prior to surgery, that is for the interval of 2 to 3 months, or if the patient is already having a good tissue, then there is no need of estrogen, specifically in young female patients. Yes, good, Noman. Yes, Daniel, proceed, please.
Then the fistula should be examined properly, the location of fistula, the size of fistula, number and erythema and inflammation around the fistula should be noted. Then there are certain tests which help to detect the small fistulas like dye in the bladder test, which include 3 swab tests or tampon tests. The presence of vesico-vaginal fistula may be confirmed by instilling a vital blue dye into the bladder per urethra and observing whether vaginal discharge is discolored. In 3 swab tests, we put 3 swabs inside the vagina. It is usually used to detect how high the fistula is. Like in urethrovaginal fistula, the lower one swab is soaked. When low in the bladder fistula VVF, then second swab is discolored, and if the VVF is higher up, then upper swab is discolored. This is the upper vaginal examination of the fistula. This this the bullous noted which is the vesicovaginal fistula. Then diagnosis. There are certain contrast studies which help to detect the vesicovaginal fistula, which include delayed CT visualization of contrast. CT cystogram may be used to isolate the bladder and see the vesicovaginal fistula. Then contrast study also helpful to detect or stage any malignancy if it is associated with VVF. Cystogram may be done to see the VVF. Its best image is in lateral position. In addition to VVF, it may also demonstrate bladder capacity, any cystocele, bladder neck competency, or vesico-ureteral reflux.
We can also use a magnetic resonance imaging in case if the patient is having a failure, cannot tolerate contrast. So this is also one of our option in diagnosing. But since most of the time we usually proceed for a CT cystogram or urogram, or in case if the serum creatinine is impaired, then we opt for cystogram only by ourselves. So we also come to conclusion after this. Yes, Daniel.
This is the cystogram lateral image, which is showing the high fistula between the bladder and the vagina. This is the fistula tract. Then this is a CT scan image which shows the communication between bladder and the vagina. And this is an axial image which is showing the VVF.
In any kind of cystogram, be it a normal cystogram or the CT cystogram or urogram, the lateral image at the time of voiding is very important. So in that we can see also that kind of fistulas which are very small, or which we can usually miss on cystoscopy as well. Yes.
On cystoscopy, the immature fistula is usually the area of localized bullous erythema is noted. In case of mature fistula, the margins becomes smooth. If it is difficult to identify the fistula, a guide wire may be used to identify the trach. The advantages of cystoscopy include it is a confirmatory test. The size may be noted in cystoscopy. Any collateral fistula may be identified. The location of uteric orifices in relation to fistula are noted. If the history of malignancy, biopsy of trach should be taken to confirm the recurrence.
Gold standard in diagnosing any VVF is cystoscopy and vaginoscopy. This is usually BCQ which come in exams across us. So if the gold standard cystoscopy, vaginoscopy is given, then it should be a gold standard. Yes.
And there are certain classifications of VVF. One of them is Valdez classification. It assesses mainly the extent of urethral involvement and whether the injury of urethra is circumferential. There are three types of Valdez classification. Type 1, the distance between distal edge of fistula and urethral meatus is more than 4 centimeter. There is not any involvement of bladder closure mechanism in type 1. While in type 2, the bladder closure mechanism is involved and the distance is of 1 to 4 centimeter or 0.5 to 1 centimeter with involvement of bladder closure mechanism at the bladder neck or mid-urethral level. Type 3 fistulas are complex fistula, which also include recto-vaginal or uterovaginal fistulas.
Okay, Daniel, please wait. Can anyone tell me? Yes, one slide, ma'am. Valdez classification. What can be the significance of this Valdez classification? I mean, other than the paper or the research work, what can be the concept behind this classification? Any idea? A clue is like, why do female patients complain of urinary leak post VVF repair? The common concept which we think that bladder gets smaller in capacity, patient may be having overflow incontinence or detrusor instability, therefore she leaks. But any idea, as we can see, the bladder closure mechanism? Yes, Noman?
Then, if the fistula is below just near the urethra or below the diagon, it is involving the urethral sphincter in the female only because they are having only the external urethral sphincter. So after the fistula repair, when we are going to repair that fistula, there should be some extra damage to that sphincter. So the patient will be leaking after he might having a stress incontinence or true incontinence after the repair also. But if the fistula is away from the trigon and away from the urethra, so there might be more success both of not leaking after VVF repair.
Yes. Basically, initially it was thought that most commonly patient or female patient which usually come after VVF closure with urinary incontinence, they must be having some kind of a detrusor instability or stress urinary incontinence due to urethral hypermobility or loosening of pubocervical ligaments. But the current concept is a concept of a tethered vagina syndrome. Now, basically, what happens that in a case of a vesicovaginal fistula repair, especially through transvaginal route, due to extensive dissection of vagina, usually around the concept of bladder neck, around bladder neck, it led to the significant scarring of vagina, and it leads to the sticking of vagina towards the bladder side and urethra, resulting in the permanent, or we can say the temporary, but most of the time it's permanent loosening of urethral meatus. And this is a reason which is currently diagnosed. This is a reason that led to the urinary leakage in these patients. It's not the stress urinary incontinence or the detrusor overactivity, but it's basically the tethered vagina syndrome. It's a new concept. And this is a reason that we are also conducting one of our study on vesicovaginal fistulas and specifically urodynamic studies after vesicovaginal fistulas. And we are trying to see all these different kinds of phenomena in that as well. So, sir.
Can we prevent this incontinence after surgery?
Yes, we can.
in patients who have involvement of urethra or bladder neck.
Yes.
Can we perform anything for them so that post-operatively they remain continent?
Yes. First of all, the extensive dissection should be there. If there is an extensive vaginal gap, vaginal layers are present and there is extensive vaginal gap, the use of some flaps with a good vascularity can also enhance a healing element to reduce the scarring of vagina. So yes, we can also do this, and we usually do this. Although we don't use flap, but we usually make a good gap without any dead space.
And the role of ceilings or
Yes, but that is usually once it is established.
but some people advocate that if there is a short urethra less than 2.4 centimeter or bladder neck is involved, then you can use slings during the surgery of VVF repair, so that to prevent incontinence afterward.
Okay.
And even some people advocate that leave it alone and then do these procedures after
In the second setting.
after some time of surgery. So both the ways they are advocated in literature.
So the purpose of this Waldich classification is not only a paperwork, but rather it gives us an idea of the urethral mobility and the vaginal fixity in the patients, and what and how many patients can complain of a urinary incontinence due to this mechanism post repair. Yes, Daniel.
Okay. And then second classification in system is a GOES classification. It includes the criteria for outcome of VVF repair. It is focused on variables that affect fistula closure, like location of fistula, size of fistula, and amount of scarring. Uh, According to the proximity to the urethral length, the type there are four types. Type 1 include distal edge of fistula is more than 3.5 centimeter from external urethral orifice. Type 2 is 2.5 to 3.5 centimeter from external urethral orifice. Type 3 is 1.5 to 2.5 centimeter. And type 4 is less than 1.5 centimeter from external urethral orifice. Then
Again, this proximity to the urethral length shows the mechanism which we have just discussed that led to either stress urinary incontinence or the fixity of the vagina, leading to the tethered vagina syndrome. Yes. Yes.
scarring, the more the scarring, the more is the grade of the GOES classification. In type 1, there is no or mild fibrosis with adequate vaginal length of more than 6 centimeter or normal capacity. In type 2, there is moderate to severe fibrosis around the fistula or vagina or reduced vaginal length or capacity. In type 3, there are special consideration like involvement of ureteric orifice. Then fistula size type A is less than 1.5 centimeter in diameter, type B 1.5 to 3 centimeter, and type C is more than 3 centimeter.
Again, this concept of fistula size gives us idea of complexity of the fistula. Usually the large fistulas, which are greater than 3.5 or 4 centimeter are considered as complex. So the outcome of fistula repair is basically can be counted or can be seen by employing a GOES code in this. Yes.
Then treatment.
Which one is more predictive for what is it?
GOES.
GOES is more predictive for the outcome.
Yes.
As compared to all digit.
Yes, Daniel.
In treatment, there is no single best treatment modality. Treatment options may vary from just catheter drainage to complex reconstructive flaps and ureteric reimplantation. The goal of treatment is cessation of urine leakage and complete return of normal urinary and genital functions. Pre-operative counseling should be done regarding the complications of the procedure, with failure, recurrence, prolonged catheter drainage, and need of further investigation and ancillary procedure. Patient should be informed regarding vaginal shortening, dyspareunia, alternation in vaginal shape due to flaps. Post-operative bladder symptoms should be explained. The change or alteration in surgical plan on table like use of flap or graft or change in approach should be properly mentioned before procedure. The management includes conservative or minimally invasive therapy and surgical repair. Conservative management is usually done before.
Daniel, wait. Please wait. Before starting the management, what can we do to get a best results in fistula patient, in VVF patient? Like patient is having fistulas, having history of multiple surgeries. What can be done to optimize their vascularity, their tissue, and their overall status? Anyone from audience? It's just like any patient who is going for a prolonged surgery need a optimal management of their every body organs and a specific parameters. So what can we do before surgery in these patients to enhance vascularity and get good results? Anyone, anything? Noman again. Anyone other than Noman, please?
First of all, from the basic, as the patient is a female, we should optimize the patient. We should build the hemoglobin status of the patient so that it will help in healing purpose and delivering of the oxygen to that tissue which we are going to be dissection. And second number, if the patient is in old enough or she is having decreased amount of estrogen in the blood, we should advise hormonal therapy intravaginally and other goes to replace the estrogen level so that these genital tissues should get maximum amount of the tissue so that they can have the best healing after the procedure. And number three, after the surgery, the patient should
Before surgery.
Before surgery.
What can we do to optimize? The nutritional optimization is very much important. The maintenance of the sanitary conditions so that the surrounding skin should not deteriorate is very important. Acidifying urine is also again very important. So these are something which we should do in the small period of time which we get after index surgery, usually around 2 to 3 months. So get tissue gets healed as much as possible. So these are the basic principles which we usually opted in every kind of a surgical patient, because we don't get patients under until unless patient is not very much stable and some of his or her nutritional parameters are not stable. So yes, the basic necessity goes for VVF patients as well. And obviously, pre-operative counseling is very important. And in this scenario, pre-operative counseling is important not only for the patient herself, but for her husband as well. So we usually ask a couple to come together. And we usually counsel them together so that the long-term results can be discussed with them openly. Yes, Daniel.
The conservative management is usually done before epithelialization. Small fistula may close spontaneously if outflow is unobstructed. Spontaneous healing with catheter drainage and anticholinergic for 6 weeks. Less than 1 centimeter fistula usually healed by himself. The rate of spontaneous closure of small VVS in different studies ranges from 8 to 28%. Early detection.
Sorry, Daniel. These are those 8 to 28% of cases, in which fistula size are very small in millimeters, as documented in the literature. They were usually 5 millimeter or overall less than 1 centimeter. And these were those fistulas in which a meticulous dissection has been done and surgeon was having a high index of suspicion. So the catheter drainage was given right from the day one, along with anticholinergic and other things to optimize the nutritional and the vascularization status as well. But in our setup, the patient usually come to us after the prolonged surgery and after an interval of gap of likely 1 month or 2 months. But nowadays, we are also getting a patient with the early results, like after 1 week or so, and they present with a vaginal discharge. So in my experience of 3 years, I haven't seen anyone to close spontaneously. Sir, is in any your experience, have you seen any fistula?
You were right that we are receiving them after long time, after 3 months, after 4 months of onset of fistula. So literature mentioned that if time is before 3 weeks, they are reaching to you before 3 weeks, then we can try for conservative treatment. Otherwise, it's useless. And second, if leakage is decreasing after catheter, and you are feeling a patient is saying that my leakage is now decreasing, after catheter, then we should give chance of catheter for 6 weeks. Otherwise, most of the time they need surgeries. So I don't remember a case because they report us after months, 3 months, 4 months, 6 months, and maybe they are tried for these conservative managements by gynecologists. They used to place catheters and give them trial for 4 to 6 weeks. Then they send them to us, and most of the time they operate them by themselves through transvaginal route. Many gynecologists perform these surgeries. So I don't remember a case, a patient who is responded to this catheter management.
With this scenario, a burning question arises that what should be the time period after which a VVF should be repaired? There are different studies state that the time period lies from 6 to 8 weeks till 3 months. So, sir, any take on this topic?
Most of the studies mention this time, 6 weeks to 3 months. The patients who are reporting you within 2 to 3 days of the fistula onset, they are the candidates if tissues are good and you feel that you can operate these cases early. So delayed repair is advocated in most of the studies rather than early surgeries. Early in those cases where you receive your patient after 2 to 3 days of the onset, and on examination you are feeling that a tissue is good, then you can go for early surgery. Our patient is insisting that you do it and let us take a chance, but provided again tissue is good. So
Tissue should
those
be
are
good.
cases for early surgery.
Yes, Daniel.
Then there is minimal invasive therapy. In patients with small epithelialized fistula, minimal invasive therapy can also be an option involving disruption of epithelial tract combined with catheterization. In this approach, a small cautery electrode is passed into the fistula tract endoscopically as far as possible. The electrode is then slowly withdrawn from the tract with electrode set on coagulation. The edges of fistula tract should blanch. It is
So,
not
what is
recommended.
in your opinion, what is the concept of this electrode placement and burning this whole fistula tract? Anyone from audience? What can happen if we applied any electrode or when this thing was first reported in 1995 when a surgeon tried to the patient was having a very small fistula was less than 5 mm or it was approximately 0.6 mm, and he fulgurated the whole tract as well as a whole the fistula on the vaginal aspect. And after 6 weeks, when the continuous drainage, catheter drainage and anticholinergics, he get a very good result. So the basic mechanism is to burn out all that fistulous tract, which led to healing, and reepithelialization of the bladder and the vagina will be done once there's fistulous tract that will be completely taken out or completely burned out. So the reepithelialization will be started from the new way. So this is basically the concept of Bugby electrode, which was first used, or rather we can also use our normal electrodes in which we used in a TURBT for burning, rolly ball. Yes. But it's
It's
better tested and it's not a very much common option for large fistulas. Less Nazish.
मैडम क्वेश्चन इज जैसे आपने कहा कि 1 सेंटीमीटर से कम का हो 5 mm तक का हो, अगर उसमें गाइड वायर नहीं जा रही या ब्लाइंड ट्रैक हो लेकिन पेशेंट आपका सिम्टोमेटिक हो लाइक इनकॉन्टिनेंस एंड ऑल ऑफ दैट, मतलब परवेजाइनल यूरिन की कंप्लेन करता हो, तो क्या उसमें भी हम ये कर सकते हैं?
हम कर सकते हैं मगर यहाँ पे हमने शायद कभी किया नहीं है इसको सर.
नहीं हमने नहीं, but localization of fistula is
It's
important.
important.
Any surgery you are performing on fistula, localization of fistula is important, and you should place something, maybe glide wire, maybe guide wire, and most of the time we are successful to localize the fistula. but sometimes you have to open it blindly. But in those cases, I remember two cases. But then we had to perform multiple surgeries on those patients because we could not localize. We opened these cases transabdominally and we tried to dissect maximum up till the bladder neck and below that, but we were not successful on those cases. And ultimately, they got relief when we localized fistula and then we closed it. So localization of fistula is important for successful repair. So we cannot subject these fistulas to diathermy or even surgery without localization.
Okay, but it can be tried.
We tried in two cases, but we failed.
Okay.
Those cases required multiple surgeries, and ultimately, I remember one lady, and we labeled her as a neurogenic bladder, but she used to come with this complaint that I'm leaking from vagina because she was holding urine 500, 600 cc in bladder.
Yeah.
So then once this team came from for workshop, and they then did EUA and they localized fistula. It was tiny one at the lateral side, and then they repaired it, and now lady is all right. So without localization, there are the chances for failure, more than 90% chances of failure. So localization is important.
Yes, Daniel.
So the minimal invasive therapy is not recommended for large VVF or thin vesicovaginal septum, non-oblique tract, significant inflammation around tract. Advantages are safe and effective, less morbidity, day care case, improved cosmesis, decreased hospital stay, and the devastating result may be failure, enlargement of fistular size, devitalizing of adjacent tissue, rendered for use them as flab in future repair.
Sir, in minimally invasive treatment, the new concept of bovine cellular porcine collagen and fibrin or sealants is also there. It's being used internationally.
It's mentioned in literature, and it's for less than 3 millimeter fistulas, less than 3 millimeter size.
Did we try it in any patient? And
No,
what about
we
result?
haven't tried. We can try in some cases.
Yes.
There are tiny fistulas. But
And especially in those cases in which we already repair and they're very small, tiny one.
You are right. We should try.
We should try. Okay. Yes, Daniel, please move ahead.
Then the surgical repair. The principles of urinary fistula management is like any other fistula management, like adequate nutrition, eliminate infection, remove or bypass distal urinary obstruction, achieve unobstructed urinary drainage, and any malignant cause of fistula should be identified. Principles of surgical repair of fistula include adequate exposure of fistula tract, debridement of any ischemic tissue, remove any foreign body or synthetic material, maintenance of hemostasis, use of well vascularized or healthy tissue flaps, watertight multiple layer closure should be done, tension free non overlapping suture lines should be there. Then the timing of repair. In case of iatrogenic fistula, they should be repaired as soon as they identified and confirmed. In case of obstetric fistula, there should be 3 to 6 month time before the repair so that tissue demarcation and settling of inflammation may achieve. In case of radiation induced fistula, there should be 6 to 12 month between the onset and the repair of the fistula. If there is any complication like urinoma or abscess, then delayed repair is ideal. Then the approach of repair depends on the size, site, and need of adjuvant procedure and the expertise of the surgeon. There are higher morbidities and complications associated with abdominal approach. Drawbacks of vaginal approach is lack of familiarity of a urologist to vaginal cuff anatomy and vaginal shortening, difficulty in exposing high fistula. Abdominal approach is usually indicated in complex fistula with ureteral injury or other intra-abdominal organ surgery like augmentation for short capacity bladder is needed.
Now, first of all, any fistula can be repaired by transvaginal route, irrespective of its location. In the past, it was mentioned that mostly supratrigonal fistulas can be repaired by transabdominal route, but now it's obsolete. Any fistula can be repaired if there is a proper retraction, if there are healthy, well vascularized tissue, and above all, the adequate flaps can be raised. So, any fistula should be given a chance to repair through transvaginal route first,
if it's accessible.
if it's accessible.
Previously, our understanding was that any fistula which is referred to us is for transabdominal repair because gynecologists cannot perform it transvaginally. And especially supratrigonal fistulas, we used to open transabdominally. But after these workshops, 2-3 workshops, we learned that you can repair any fistula of any size and any site if it's accessible through transvaginal route. Vagina is capacious and you are capable to perform.
Surgery.
So you should try for transvaginal route until unless there is indication for transabdominal like ureteric involvement or bladder is small, you want to augment it as well. But we should try for transvaginal because literature mentioned that more than 90% of fistulas are repaired nowadays by transvaginal route. So it is less morbid, less operation time, less hospital stay, no big scar, big surgery. So I think we should try, and we are trying nowadays.
Yes.
We are trying our.
Fistulas are repaired by transvaginal.
We start with the UA in the morning, and we try to do it transvaginally. If it's not possible, then we go for transabdominal route.
Yes.
Track, track excision should be done during repair of fistula. Track excision ensure clean, well vascularized, viable edges approximation. The disadvantage is increase in defect size, tension in repair, bleeding if cautery is used, then impaired healing.
Now, there are again two school of thoughts regarding track excision. One school of thought said that if we will perform track excision, will lead to the oversizing of fistulas. And one school of thought usually says that this is a track which, although having not such a good vascularity, it gives strength to the edges of the fistula at the time of the repair. So, as far as we have seen, sir, I haven't or we haven't done for any track excision until unless it is so big that it impairs the suture approximation.
Previously, we were doing this, we were excising, but now we are not excising the track because of these 2-3 things: size and bleeding. Because whenever there is bleeding, then catheters used to get blocked, and then again there is chances of failure. So nowadays we are not excising the track. And one more benefit of not excising is that this also gives the strength through your suture line as well. These margins of the fistula, when you take suture, it also helps in giving it in strength. So nowadays we are not excising, and I think our results are not bad nowadays, transvaginal repair.
Yes.
So both things are mentioned in literature, and even we can see in our cases, randomize our cases, and in some cases we excise this track and in some not, but I think results are
Yes,
good
we can.
in our cases.
We can. Yes, Daniel, bit fast, please.
The vaginal technique of fistula repair includes flap splitting technique, which is more commonly used, in which there dissection and repair in layers is done. 3-layer closure without use of any adjuvant flap, and 4-layer closure if the flap is used. The excessive use of cautery should be avoided. Intraoperative bleeding should be controlled with fine absorbable suture. This is the diagram showing the repair per vaginally. There is proper exposure by applying stay sutures around the vagina. The catheter is placed inside the VVF fistula site, and anteriorly vaginal layer is being dissected. Here, the vaginal layer is being dissected posteriorly, and the fistula tract is closed initially horizontally, and then perivesical fat or perivesical fascia is closed in a vertical layer, and then the vaginal layer is being closed. The complications include recurrence, vaginal shortening, and stenosis. Then trans-abdominal technique is a preferred approach in VVF with adjuvant procedure associated with longer recovery time and long-term hospitalization, greater blood loss, and cosmetic deformity. Approach usually include suprapubic, intraperitoneal, or extraperitoneal, transvesical approach, and a laparoscopic or robotic approach. First successful robotic VVF repair was performed in 2005. This is a diagram showing per abdominal repair of the VVF. In this diagram, the bladder is bivalved up to the VVF site. The trach is being excised here, and then vaginal layer and vesical layer is being closed separately in multiple layers, and omentum is being interposed between the VVF. This is the diagram showing the VVF. This is the VVF. The ureteric catheters are placed, splints are placed in UOs to identify them, and the repair is being done. Adjuvant procedure may include a use of greater omentum or peritoneal flap. Greater omentum is most commonly used adjuvant procedure. It's favorable because easily mobilized with good vascular pedicle into the deep pelvis without tension. Its lymphatic properties and healing in presence of infection. Peritoneal flap may also be used in high-lying post-hysterectomy VVF. Then there's a certain flap and graft may be used during repair, usually used in irradiated tissue, obstructed fistula, failed prior attempts, and large fistula. Graft and flaps may include Martius flap, gracilis muscle flap, labial myocutaneous flap, cerebromuscular intestinal flap, rectus abdominal muscle flap, and graft from bladder mucosa. Martius flap is most commonly used. It is a fibrofatty labial flap, usually used for low or distal fistula. Preferred tissue for fistula involving trigone, bladder neck, and urethra. Blood supply comes from internal and external pudendal artery and obturator artery. There is bladder mucosa flap harvested by open hysterectomy. Outcomes, the success rate either through vaginal or abdominal approach in excess of 85%. Median overall closure rate is 94% developed countries and 87% in developing countries. Results are better with transvaginal approach. Involvement of sphincter mechanism does not carry satisfactory result despite good closure. Stress urinary incontinence is major disturbing factor after closure. Then VVF can be a dilemma to female that grossly disturb personal, social, and sexual aspects, rendering patient socially isolated and affect quality of life. Use of catheters, pads to remain dry cause financial and psychological burden. It becomes difficult for patient to carry out her normal religious obligations. Recurrent UTI, smell of urine, social isolation, sexual dysfunction also invokes suicidal tendencies. Chances of failure, use of adjuvant procedure, prolonged hospitalization, post-surgical complication always remain fearful for patient. Thank you.